And I'm Dr. Kevin Cope. I'm the medical director from Mountain Valley Hospice and Palliative Care. And we've got some people online, and also we'll be putting this on YouTube. So welcome if you're watching live or on YouTube. I just wanted to take a few minutes to talk to you a little bit more about our programs at Mountain Valley Hospice and Palliative Care. We have a home-based palliative care program. If we can get this, yep. And our program helps your patients get symptom relief from their serious illnesses at home. We're going to be talking about some of the symptoms this afternoon with the nausea and vomiting, but that's one of the symptoms we help patients get relief from at home. We also explore patients' wishes for how aggressive they want their treatment to be in the future. And then we also have our hospice care program for patients that during the normal course of their disease have less than 6-month prognosis. Just a reminder, we take patients from all of Fulton, Montgomery, Hamilton, and Saratoga counties. We have a 24/7 hotline number, 518-725-4545, and we also have a clinical fax, which is HIPAA secure, where referrals can be faxed to us. And we also, with our palliative care patients, when they're ready, we do advise to move them to hospice care when they do have a prognosis less than 6 months. So we monitor patients. So really, you can send your referrals to us and we can figure out where they fall in, whether it's palliative care or hospice care. And when they are ready for hospice care, we can move them to hospice care. So, we're going to talk about nausea and vomiting. And one of the most common symptoms, let me just see here, make sure I got my video up. Okay. One of the most common symptoms in patients with serious illness is nausea and vomiting. It causes a significant amount of distress and has a significant impact on the quality of life. And if untreated, persistent nausea and vomiting can lead to dehydration, electrolyte disturbance, weight loss, anorexia, emotional distress. Just want to make sure I've got this pulled up here. So it's important to try and treat the nausea and vomiting before it leads to these problems. So there are 4 basic pathways that can trigger nausea and vomiting in a person. And I'm going to be talking about these 4 and try and simplify this as much as possible. So the first one I wanted to mention is the chemoreceptor trigger zone, what they call the CTZ. That's a part of the brain that triggers the vomiting. There is the GI tract, which is a big factor in triggering nausea and vomiting. There is the vestibular tract that can trigger vomiting. And there is the cerebral cortex, which problems in the cerebral cortex like tumors, metastatic lesions, bleeds can cause trigger vomiting. With the chemoreceptor trigger zone, that's the first one we talked about, and that area of the brain is stimulated by endogenous toxic substances produced in acute infectious diseases. So if a person is septic, that can trigger that zone of the brain to cause vomiting. Metabolic disorders such as uremia, diabetic ketoacidosis, and also another big factor in triggering this pathway is drugs such as antibiotics and other drugs can trigger the CTZ pathway. And I'm going to be talking about how this pathway is mediated by both dopamine and serotonin. So keep that in mind. Each pathway is mediated by different hormones, and this one is mediated by both dopamine and serotonin, which comes into play when we're talking about the best treatment options for the CTZ triggers for nausea. So The other is one of the other pathways we talked about out of the four. The second one is the GI tract, and this is a very common one. GI tract issues cause nausea and vomiting by causing delayed gastric emptying and include gastroenteritis, COVID-19, gastroparesis, obstruction, and a big one, especially in cancer patients, is radiation and chemotherapy, which can definitely cause GI tract issues, delayed gastric emptying, slowing of gastric emptying, and cause trigger nausea and vomiting. So this pathway is also mediated by the same two hormones, the dopamine and the serotonin hormones. So again, keep that in mind when we talk about the best treatments for these type of issues triggered by the GI tract. The vestibular tract, typically, this is where the room is spinning. Patients describe that. They causes that affect the inner ear balance, such as vestibular neuritis, labyrinthitis, benign positional vertigo, a vestibular schwannoma tumor there can cause this in the inner ear. Motion sickness triggers this tract. And this tract is mediated by two other different hormones, the histamine and the acetylcholine hormones. So again, that will come into play when if you have somebody that's having nausea and vomiting from vestibular tract problems, we'll want to target treatments based on those two hormones, the histamine and acetylcholine pathway there. So. And then the fourth one we talked about was the cerebral cortex issue, and these issues cause increased intracranial pressure and trigger the nausea and vomiting that way. So tumors, bleeds, that type of thing are triggered by the cerebral cortex pathway. And those are mediated by the GABA hormone and the H1 hormones. So again, just to kind of review, we've got the four pathways that trigger nausea and vomiting, the CTZ, the chemoreceptor trigger zone, the GI tract issues, the vestibular tract issues, and the cerebral cortex. So we want to pick treatments that will help each one of those pathways and block the hormones or mediators that are involved with those pathways. So as I pointed out, the CTZ and the GI tract are both mediated by the dopamine and serotonin hormones. So when we talk about treatments, we want to pick dopamine and antagonists, something that's going to be blocking that pathway. So certain drugs are called dopamine antagonists, and these are your compazine, which is prochlorperazine. That's a classic one. That's a dopamine antagonist. And then also your metoclopropamide is a very common one used that we use. Although keep in mind that use of metoclopropamide for 3 months or more is associated with a risk for tardive dyskinesia, particularly in patients with renal, hepatic impairment, diabetes, or who are older than 70. But metoclopropamide is a good drug that can be used for nausea and vomiting triggered by to block the dopamine pathway. Haldol, haloperidol, we use very commonly in hospice patients. That helps the nausea because it is a dopamine antagonist, 1 to 2 milligrams a day, typical dose. And then studies are emerging about olanzapine, which is brand name Zyprexa, a 10 milligram dose. There's been a number of studies done now showing that this is quite effective for chemotherapy-induced nausea and vomiting, or CINV. But there is a level of discomfort that prescribers have because it is a second-generation antipsychotic. But the chemotherapy-induced nausea and vomiting, as I mentioned, tends to affect the GI tract, so a dopamine antagonist is helpful to try and counteract that. And a lot of times what we would do in severe cases is combine that with a serotonin antagonist, because as I pointed out, the dopamine and the serotonin pathways are both involved with GI tract issues and also CTZ zone issues for that pathway. So as far as serotonin antagonists go, ondansetron, brand name Zofran, is the most prescribed antiemetic in this group. Beyond their role for the chemotherapy-induced nausea and vomiting, the CINV, they are preferred antiemetic options in patients with Parkinson's, Lewy body dementia, or restless leg syndrome because of a lack of effects on the dopamine receptor. So if you're just looking for a medication that will block serotonins, ondansetron is a great option, and because it won't block the dopamine receptors like the previous class we just talked about. So keep in mind that if you're treating Parkinson's or Lewy body dementia or restless leg syndrome. So just again to reiterate, we talked about the CTZ, we talked about GI tract. Now we're going to talk about vestibular tract pathway. And those respond to drugs that block the histamine and the anticholinergic pathways. Remember, I said those two hormones were involved. The histamine and anticholinergic are involved in the vestibular tract pathway. So good drugs that block histamines are promethazine, which is Phenergan, and meclizine, that's another one. Other antihistamines, even diphenhydramine, Benadryl, will block histamine mediation and give some relief if the nausea is being triggered by a vestibular tract issue. Scopolamine is a good drug that also will, scopolamine actually blocks the anticholinergic mediation, so that will help the nausea from vestibular tract issues by mediating that pathway and blocking that pathway, the anticholinergic, so it'll help nausea that way. The fourth pathway that triggers nausea and vomiting in the body is the cerebral cortex. And the cerebral cortex pathway is treated by drugs that reduce intracranial pressure. And dexamethasone is the most commonly prescribed one because it is very effective in reducing intracranial pressure, which can relieve the nausea and vomiting that way. So just want to talk about a couple other miscellaneous agents that are out there. The cannabinoids, the prescription agents such as dronabinol, which is brand name Marinol, is available. This is FDA approved now for post-operative nausea and vomiting, PONV, and the chemotherapy-induced nausea and vomiting, the CINV, and they've shown effectiveness in some published trials. So keep that in mind if you have a resistant case, especially of nausea and vomiting in a post-op nausea or vomiting patient or a chemotherapy-induced nausea and vomiting patient. And I want to spend a minute talking about opioid-induced nausea and vomiting because this is something we commonly see and have to deal with, especially in palliative care and hospice. So the opioids trigger the GI tract pathway by slowing down GI motility. And so that pathway is getting triggered for the nausea and vomiting. So one issue would be to try a lower dose of opioid, which may not cause as much GI motility issues, and that might help overcome the nausea and vomiting. But if you can't switch to a lower dose, you can consider switching to a different opioid because one may have less effect on the GI motility issues. So the opioid-induced nausea and vomiting, since it affects the GI tract, you would want to treat this with the anti-dopaminergic agents that we talked about that block the dopamine pathways. So Haldol is a great choice there, or an anti-serotonin agent that blocks the serotonin pathways. So ondansetron or Zofran is a great choice for that. And sometimes you would want to combine both of them to get the maximum effect if a person's really struggling with opioid-induced nausea and vomiting. Want to mention anxiety or anticipatory vomiting. You know, some people, even the sight of something or the smell of something will actually trigger vomiting and trigger nausea and vomiting. And anxiety can be a factor in this as well. And for those issues that if you're dealing with that, you want to, lorazepam is actually very effective in preventing this. So just again, a summary and closing here. We've got the 4 pathways that trigger nausea and vomiting, the chemoreceptor trigger zone, the CTZ pathway. That's the first one. The second one we talked about was the GI tract. The third one, the vestibular tract, and the fourth one, the cerebral cortex. And you want to tailor your medications based on the hormones that each one of those triggers. So to best treat nausea and vomiting in your patients. So I want to thank you for your support and for your attention. Please email questions on any palliative care issues or hospice issues to me at kevin.cope@mvhcares.org or leave me a message on my cell, 518-669-1439. I will email out the YouTube recording of this and the PowerPoint, and I do want to point out that I want to give thanks to the Center to Advance Palliative Care for their input on this topic. They have a lot of great information on their website about this, so very helpful to me. So